Hello, folks. Both good afternoon to both everyone here in R&T. Thank you so much for coming in person. We're so excited about our seminar series and reuniting people and faces to discuss HIV and new advances in research and practice. Welcome also very much to our viewers on Zoom and participants on Zoom. You are not visible to the room, but we are definitely very aware of your presence, and we will be taking your questions at the end of the talk. I'm Adrienne Shapiro. I'm one of the co-organizers of the UW-Fred Hutch CFAR seminar series, and we're so excited to welcome you to today's seminar series with our second of the year with Dr. Aadia Rana. We're very excited to welcome her to Seattle and here to Harborview campus today. Dr. Rana is Associate Professor of Medicine at Hersink University of Alabama-Birmingham School of Medicine and an Associate Scientist at the UAB CFAR, where she serves as Director of the Ending HIV in Alabama Scientific Working Group, which includes a broad range of clinical, epidemiologic, sociobehavioral researchers, as well as community and public health partners, catalyzing Birmingham and Alabama's progression towards the UNAIDS 90-90-90 goals. She received her medical degree from UAB, completed internal medicine residency at Case Western, and a fellowship in infectious diseases and HIV health services research from Brown University. Her NIH-funded research focuses on assessing inequities in HIV outcomes and care utilization, and development and implementation of clinic and community-based interventions to improve outcomes for people with and at risk of HIV. She's chair of the ACTG Protocol 5359, a randomized controlled trial testing a strategy of long-acting injectable antiretroviral therapy with conditional economic incentives in people with HIV with a history of non-adherence. Dr. Rana has been instrumental in the development of key community and public health partnerships critical to achieving the Ending the HIV Epidemic goals, and is PI or co-I on numerous HIV outcomes and effectiveness hybrid and implementation science grants conducted in collaboration with public health agencies across the Deep South. We are so delighted. Welcome, Dr. Rana. Thank you.
Thank you so much, Adrienne. It's really been such a pleasure meeting with so many people here today, and both new faces and some old faces. So it's been really great. And I think a few things, I think the highlight has certainly been seeing how much overlap there is in our science and in the interest and the work that we're doing, in particular with ending the epidemic initiatives and really centering it around public health agencies. So I think this is going to be a great opportunity. I think the other thing that we all share deeply is Dr. Jeannie Marazzo left both of us. And so that's also been a great thing to commiserate. Misery loves company. No, we're very excited about her and her position and the challenges it brings, but also the opportunities. So I'm excited to talk to you about some of the work that we've been doing in Alabama. And again, as Adrienne mentioned, really kind of centering it in among all of the work that we're doing within our CFAR, but also with our community-based organizations and the state and local health departments that honestly predated this whole ending the epidemic. It was one of those, you kind of feel like Nostradamus, really. Well, we were trying to do this before anyway, and now we're doing it now. And so I'm really looking forward to sharing some of this work and getting feedback and input from you all on this as well. So we're going to do a brief, I know people in this room are well versed on the epidemic in the US, but just going to provide a brief overview and then talk a little bit about the initiative, and then I think really focus our talk on some of the work that we're doing in Alabama. So as you all know, I mean, the epidemic in the US, there's about over 1 million people living with HIV, and we are still pretty stagnant with about 30 to 40,000 new infections. I know COVID kind of skewed the numbers a little bit, and there was a noted significant drop in 2020, but that was really connected to a reduction in testing as well. But the concentration of the epidemic is certainly still in certain regions, and particularly in the Deep South. The Deep South makes up About 30%, or the Southern US makes about 30% of the population of the United States, but about 51% of all new HIV infections occur in the Southern states. And we're probably familiar with the care continuum. Of course, this is cross-sectional, looking at estimates of the proportion of people with HIV who are diagnosed, which is about 87%. But as we go down, these numbers drop significantly, with only about 57% achieving what we consider sort of our both public health and personal goal of viral suppression. And then I think when we parse who those people are and sort of the differences in the demographic characteristics, I think it's important for us to understand that there are certain populations that probably have even worse outcomes than we're already seeing. And so that includes, younger age, race, ethnicity, particularly among Black and African Americans, and then men who inject drugs. Across each of these parameters of the care continuum certainly have worse outcomes. And then I think the big context is this next slide. When we look at how we, the wealthiest country in the world, are doing compared to our sort of equal in terms of at least wealth equality or wealth distribution countries. And every time I look at this slide or present this slide in a setting that's not in the US, there are these gasps in the audience. They're like, oh, what? And I'm like, yeah, like this is our lives. This is how we work. And I think, part of it is really understanding the context, right? And understanding all of the things that inform the United States being dead last. And I think part of that is it's important to understand that, that is a cross-section, but engagement in viral suppression is actually a very dynamic process. So Kim Powers did this, I think, very simple but very elegant analysis in North Carolina, looking at all individuals who were newly diagnosed and entered into their state health department surveillance. And they use CD4 viral load as sort of proxies of care to describe patterns of engagement longitudinally over a period of 8 years or so. And what they found is that about a quarter of people after they're diagnosed consistently stay engaged in care. And about a quarter of people after they're diagnosed never really engage in care. And then in between, we have these different patterns. We have people who are steadily declining. We have people who early increasing, late increasing. And of course, with surveillance data, it's very limited as to what inferences you can make as to who these people are. Not surprisingly, older age was probably the only predictor that they could find in this population. But really trying to contextualize these patterns of engagement are important as we try to develop the interventions to improve these outcomes. So the model that I tend to use in my sort of conceptual frameworks is the socioecological model of HIV risk and vulnerability. And this was first developed by Steph Burrell, mostly for HIV prevention, but really has been adapted even for HIV treatment as well. So it acknowledges that there are 5 different stages that need to be understood as we are both trying to contextualize some of these outcomes as well as develop interventions to impact them. And the first one is, what we see in clinic. So the individual level factors. We see our patients, we see their challenges with substance use, with mental health, poverty, and sort of how can we assess and impact those. The second are network level factors. So what's going on in terms of HIV prevalence in the network of the people that we're seeing, in terms of, STI and other levels of association. What are their ages? Who are they hanging out with? Then there's the community level factor. So within the community, what are the experiences of stigma, and not just related to HIV, but certainly related to the intersectional stigmas of poverty and sexual and gender identity as well, racism. So understanding that, I think, is also important. And then the fourth is where, I think a lot of our minds go to, especially when we're talking about differences in regions around the country, or the social and structural level factors. What are the policies in place? Is did Medicaid expand? Is needle exchange legal or available or accessible? What is the accessibility of ART and PrEP and medication assisted treatment? And I think the final stage, which we all state at the beginning in our background, like, here's the incidence, this is what's going on in sort of, in terms of the prevalence and the levels of viremia, the community viral load. So I think this is a good framework every time I'm sort of trying to think about, okay, what are the next steps here? And then I think the other thing that we all have to acknowledge, I mean, particularly in our non-Medicaid expansion states, is how fragmented healthcare delivery is. So when we talk about even HIV testing, prevention, and care, you're running the whole slate of, like, is it at a private health clinic? You could do it at a public health clinic. There might be FQHCs, academic health centers. And then specifically for those of us who work among pregnant women, my HIV infected woman will get HIV care with me, and then she'll go somewhere else to get her pregnancy care. And then the infant has to go somewhere else to get tested. But somehow we've got to track it all together, and they're all using different EMRs, and we're trying to figure out what the outcomes are. It can be very, very difficult. And then of course the funding, whether it's private insurance, Medicare, Medicaid, and then the federal Ryan White programs, which in and of themselves are limited. They can provide HIV care, but their prevention care is limited to HIV testing of their partners, and then maybe condom distribution. PrEP cannot be distributed by Ryan White Part C clinics. And so, and that translates to, even with Medicaid expansion in states, still a pretty high rate of lack of insurance or limited insurance among people with HIV. And even when we look at Medicaid expansion states, I mean, there are certainly disparities in expansion states. Those still persist, racial and ethnic disparities, but gosh, way more pronounced in non-expansion states as well. And so, I mean, at the crux of it, the big message for the Ending the Epidemic initiative really comes down to this. We have done the clinical trials. We know what the tools are. We have the biomedical, tools that are needed, but implementation is certainly critical. And how are we going to do this, both for, primary prevention and then ultimately for secondary prevention as well? And so this is sort of my very simplistic model. Like, this is what it's going to take, right? Like, we need sort of public health agencies who have the mandate, have the agency, have the authority, but also have the data. And they need to be supported by academic institutions who have the resources and the science and the methodology to help them interpret all of those things. And you can't do it without the community, because they're the ones who are going to help direct your efforts and tell you this is how to effectively implement, and be your voice and be your champion for the population that they serve. And so it really is going to take all of those. And as simplistic as it is, gosh, it's been really hard to operationalize. It's been really hard to do. So the Ending the Epidemic initiative, as you all know, the 2019 initiative, which sort of tasks all of the DHHS funded agencies, NIH, CDC, HRSA, SAMHSA, Bureau of the Indian Health Service, to all work together in 48 highest burden counties, and then 7 states that have what's defined as a substantial rural HIV burden. And of course, the pillars are diagnose, treat, prevent, and then respond, which kind of has its own challenges, as Roxanne and I were talking earlier today. And so one of those 7 states is Alabama. And I think the other unique thing about Alabama is it's the only of the 7 states that has a CFAR in it as well. And so this is a map of Alabama for those of you who might be unfamiliar. So Birmingham is in the central part of Alabama. It's the county is Jefferson County. It has the highest incidence and prevalence of HIV in the state. We have about 5 million people in the state, and it's estimated to be about 16,000 people living with HIV throughout the state. Mobile County, which I'll talk in more detail about, sort of the second highest prevalence. So these are urban, and then Montgomery is the capital. So those are kind of the highest counties in terms of prevalence. But as you can see, we have this kind of swath of high prevalence counties in the center. And this area of the state is known as the Black Belt. And it's so called because of its like rich agricultural soil. And so a very rural area. But as you can see, very high prevalence, so not very densely populated, and individuals in this area experience disparities of many types. This is also called the stroke belt. This is also called the diabetes belt. So in general, this area has been identified by the United Nations as an area of need, which is should be very embarrassing for our state. And so this is kind of, the landscape of what we're working with when we talk about the state being an EHE state. About 17% of the population lives below federal poverty line. And the highest uninsured population are men between the ages of 25 and 34. So when you think about who gets HIV in our state, it's this particular, certainly population. And we've had a fairly stagnant rate of about 600 to 700 new infections per year. And so whereas sort of, death rates have stayed the same, and, when we've gone up and down, but overall a fairly frustratingly stagnant rate of new HIV infections. And so this is our care continuum, the latest data, which is 3 years old, from our state health department. And so this is 2020, so with the caveat that the retention and care number is way lower, potentially because of lack of viral loads collected because of the pandemic. But 59% is sort of where we have been, and then different parts of the state. So in this map here, these are our public health areas. And so the state health department releases care continuums for each of the public health areas. Alabama also has the highest PrEP, one of the 3 highest PrEP to need ratios in the country. So if you guys aren't familiar, so Patrick Sullivan and his colleagues, they used commercial pharmacy data to count PrEP users, and they came up with this equation. So the number of active PrEP users divided by the number of new diagnoses in that group. So you want to have more PrEP users and fewer diagnoses. And so the biggest disparities, or the pronounced disparities in Alabama, as you can see, among whites, the PrEP to need ratio is 11, and then among Hispanics it's 8, and then Blacks is 1.95. And people who have looked at this data for Alabama specifically estimate that less than 20% of African American men who are estimated to need PrEP have ever received a prescription for PrEP or even had a discussion with regards to PrEP. So certainly a huge need. And so just to sort of talk about how, in this fragmented healthcare sort of society, how some of the discussion started. So back in 2010, there was sort of this vision, you have the health department, we have these separate clinics. St. George's Clinic was our county health clinic, UAB Family Clinic is our Part D funded clinic, 1917 Clinic is a large Part C funded clinic. And then everybody was doing things in their own silo. And so the sort of mandate was to let's all get together and see if we can create some sort of health information exchange system where at least we could sign releases to each other, where we would be able to track each other and say, if somebody got referred here, did they also get referred to the clinic? And so allow sharing data essentially. And so meetings were started, that what was now called the Jefferson County HIV Coalition was formed, and to sort of think about how we can operationalize something like this. And so at that time, or soon after, the CDC had put out a variety of sort of funding opportunities where you could get funding for HIV prevention, sort of grants or ideas. And if you got it applied as a single agency, you would get $450,000 a year, but if you applied as a coalition, you could get a lot more money. And so that brought together two big opportunities, grants called Game Changer and BCHIP, Birmingham Comprehensive High Impact Prevention, which was led by our community-based agencies, AIDS Alabama and Birmingham AIDS Outreach, partnered with CFAR to do the evaluation, and then working with Jefferson County Health Department to help facilitate referrals for prevention and PrEP. And so that was sort of kind of like, all right, kumbaya, let's all get together, and culminated with a Ending AIDS Deep South Summit that was attended by CFARs from the South, as well as community agencies as well. And that also led to the formation of the Alabama Regional Quality Management Group. So this is actually a statewide consortium of Ryan White funded clinics, so Part C funded clinics. And so they had received a sort of requirement that they needed to do continuous quality improvement, and so to develop a plan as part of a HRSA requirement. And so they came to the CFAR and said, can you help us with this? And so we're like, yes, we can. And so quarterly, the clinics all come down to Birmingham. We're now back in person as of last year. And it's really a quality improvement focus with quarterly sharing of aggregate data. So all of these clinics, so the stars are actual clinic sites, and the circles are that correspond with the color, the telehealth sites of those clinics. Come and they share their new diagnoses. What are their viral suppression rates? What is their retention rate? And also, what are their missed visit rates? And it's an opportunity for them to talk about best practices, what's working. People from the state health department are there. So if they have complaints about, things that the health department is doing, it's an opportunity for them to have the voice. And then for us, from the CFAR perspective, it's our opportunity to share our research with them, to say, hey, you guys participated in this with us, here's the data for that, or hey, there's this grant application, would you be interested in joining with us on that? And so that's been a very, both, I think, productive as well as growing relationship from like our CFAR and these, Ryan White clinics. And so, when we continue to meet, continue to grow, and continue to group, and the Birmingham Unite and what became the HIV/AIDS Community Coalition, sort of has these successes, which include getting these two collaborative CDC prevention grants. They count integrated delivery across agencies. And, who knows what, I think it took everything together, but also a 25% reduction in new HIV cases in Jefferson County as well. And so around that time in 2017, I came to UAB, and our CFAR was up for competition at that time. And so we developed a scientific working group. And so that was in 2017. And so using the UNAIDS sort of 90-90-90 framework, we created this scientific working group with specific areas, focused on both testing and prevention, ART care engagement, and then sort of like clinic-based interventions for viral suppression. And we were trying to leverage our experts in behavioral and community sciences and clinical sciences, and of course the expertise of biostats and epidemiologists to sort of try to answer some fundamental questions about HIV care in Alabama. So what aspects of our approach to HIV prevention are actually effective? What are the populations that are not being served effectively or at all? And then how can we comprehensively yet cost effectively improve access to an engagement with HIV care? And how can we improve outreach to increase knowledge of services available? And what are the broad community assets or resources that we as the CFAR could help come and bring together? And so one of the first things we did as part of our SWIG is to create a funding mechanism, small developmental grants, about $25,000, so not much. And so what we count as our successes is 4 of our awardees have gone on to get either EHE supplements as well as K awards. And Livy, I haven't put that up there. She got an internal K as well. And these are all either prevention or epidemiologic work focused on work in Alabama as well. We worked with commercial lab data, so LabCorp and Quest, and we were entrepreneurial with our 340B funds to purchase those commercial lab data to create for people who get, sorry, let me step back. I think I'm speaking too quickly here. In Alabama, most of the labs that are done are by the commercial labs, so LabCorp or Quest. And so HIV testing and CD4s and viral loads and all of those are done that. So what we want to do was to try and get an assessment of who's been tested and who has not been tested. And so we did that by acquiring 3 different data sets. One, we purchased data from LabCorp and Quest, which included things like HIV testing, but also hepatitis, STI testing, syphilis testing, as well as drug screens. It's de-identified in the sense that we don't know who these individual people are. We have 5-digit zip code level data, but it provides a little bit of a geographic map as to what's going on. We also have surveillance data from the state. That's more HIV incidence. And then we have STI data from the state as well. And that's all limited to zip code data only, 5-digit zip code data. And so the goal was that CFAR investigators could use this data to either inform their grant applications or in a sort of very limited way, like describe why they're targeting their particular public health interventions in the areas that they're doing that. The other thing that we were able to be sort of entrepreneurial about was these community funding grants. So we collaborated with the 1917 clinic using 340B funds and to identify community organizations or create this application process. So community organizations could apply for a 1-year pilot grant, could not be research because it's 340B funding, right? But the mission was to reach first the 90-90-90 and then ending the epidemic goals. But what we would do is we would offer evaluation for that, for their projects, and they would partner with a CFAR investigator who would help them develop the M&E for their project, as it were. And so we have funded several projects in this way, and I think the big key for all of these projects has been the development of these community CFAR relationships. And so that has led to a number of additional grant opportunities, additional EHE supplements, and then there are also certainly RFAs that are geared towards, academic community partnerships that this helps to lay the groundwork for. And so just to share some of the projects that have been related to these growing relationships. So Dr. Leticia Alopre, she is an HIV ID clinician researcher and really working sort of in the PrEP space in Alabama. And so, it's really hard to get women to participate in research, much less African-American women in rural Alabama. So kudos to her team for getting 304 women from the Black Belt And so she did a discrete choice analysis model trying to ascertain, what are the HIV PrEP preferences for like African-American women living in the South or living in rural Alabama specifically. And so the first questions were related to where they would be willing to get their PrEP care. And so interestingly, most women were very interested in getting it at a doctor's office or family planning, but less likely to want to get it either online, at a pharmacy, definitely not in an STD clinic. And interestingly, not that interested in telehealth. Now, so this is pre-COVID. Maybe things have changed. It's hard to know. And then she also asked about medication form, and the women were very interested in long-acting shots and in the pills, and less interested in implant and vaginal ring. And I don't have this data, but this also corresponded to how they felt about birth control too, the same format, which is very interesting, I thought. And maybe that because that's their conception, like they were like, what are you talking about? Oh, like birth control. Okay, I prefer long acting and I prefer pill, but not so much implant and vaginal ring. It's interesting. And then Lynn Matthews used our commercial data sets and the surveillance data sets to identify cold spots of low HIV testing rates in the state. And she used that data to work with a community-based organization that works in the Black Belt, Montgomery AIDS Outreach, which then said, okay, how can we take this data, create a sort of community-facing message with regards to testing and PrEP access, and then you, with your knowledge of the community, use this in order to scale up and disseminate sort of, community-based testing practices. And so this is sort of just a map of where they showed where the rate was of HIV tests, and then the areas of higher prevalence, and then sort of the overlap of highest prevalence and incidence. And these are the areas where we need to target in terms of testing. So one of my projects in this space is a partnership with the 3 state health departments in Alabama, Mississippi, and Louisiana. And so what we were doing was wanting to use essentially secondary analysis, wanting to use surveillance data to assess geographic variability and time to viral suppression. And time to viral suppression in particular was of interest, but because for us, it's a kind of unique indicator. Like we have the cross-sectional things of like, here's diagnosis and here's who's retained in care and who's virally suppressed. But time to viral suppression is this kind of unique indicator. There's this collective effectiveness, at least in the region, where you're really assessing, okay, how long it takes, or from the time somebody is diagnosed, they have to get linked to care. And then after they get linked to care, they have to get started on medication, and then they have to take their medication. And so time to viral suppression itself sort of shows what's going on potentially for all of those aspects in a certain area. And what we found when we initially did this work just focused on Alabama and kind of using public health area data, which we could not get from our state and ultimately had to get from the CDC, all the challenge of working with public health agencies, found that even within our state, there was pretty dramatic geographic variability in time to viral suppression. And so, and we had initially thought that, man, the rural areas are going to do really poorly and the urban areas are going to do really well. And it was almost flipped. The rural areas actually did much better in terms of time to viral suppression. And so really trying to understand what informs this heterogeneity is critical as we're trying to say, let's implement such and such intervention in terms of ending the epidemic. So we worked with the 3 state health departments to identify between 2012 to 2019, all individuals from Alabama, Louisiana, Mississippi, and we used EHARs. And so we developed a common data structure across these 3 states. We both with us at UAB and then with the health departments. They're the ones who are most familiar, of course, with the data. And we even conferred with the CDC, Irene Hall at that time, who was in HIV surveillance. And so we developed the code, but the analysis was all done behind the walls at the health departments. And then they transmitted summary statistics to us, which we combined using meta-analytic techniques. So we use the Kaplan-Meier method to describe time to viral suppression by year of diagnosis. And we divided it 2012 to 2015 and 2016 to 2019. And the reason we did that was there were a few changes. So end of 2015 is when universal test and treat was sort of became part of the policy. That's also when guidelines changed that integrase inhibitors became first line. And so those have a much quicker time to viral suppression than the protease inhibitors or the NNRTIs. And then the other thing that happened was in mid-2016, Louisiana became the first and so far only of these 3 states to expand Medicaid. And so we wanted to see if we could we wanted to take that into consideration and then sort of split the analysis that way. And so we conducted sort of state-specific, but also meta-analysis of Cox proportional hazards models to examine associations with sort of the parameters that are available in EHARs, which are very limited. And so we had about almost 17,000 people included in this analysis, with about 3,600 in Mississippi. There's about 5,000 in Alabama, 8,000 in Louisiana. So across all 3 states, approximately half were new diagnosis between the ages of 25 to 44, with 3/4 reporting male sex at birth, and over 70% identified as Black race, with the primary method of transmission, men who have sex with men, in about slightly less than half, and 30% reporting heterosexual transmission. And this has been pretty stagnant, that 25% of these new diagnoses present with advanced CDC stage 3 at diagnosis. And all 3 states, the proportion of those that presented at stage 3 really didn't change between the 2 time periods, staying roughly at about 25%. And so just to show, so Mississippi, back between 2012 and 2015, barely 30% achieved viral suppression in the first 180 days. And even of those who achieved, they took almost a year to do so, about 331 days. That improved to a little over 50% achieving with a median time of 160 days. Alabama, also about 40% achieving in 211 days. And that improved to 135 with about 60% achieving within 6 months. And then Louisiana started kind of in the middle of the pack with about 40% at 241 days, but definitely the most dramatic improvement of all 3 states. So it's also the largest state and a sharply reduced, median time of only 118 days. I will still point out, though, that the best state, only 60% of those diagnosed achieved viral suppression within 6 months. So in our analysis of variables, there's really, I think, for those of us who do, like, this has been pretty commonly reported in terms of predictors of outcomes, that, younger age, male sex at birth, non-white race, and non-MSM transmission were associated with a longer time to viral suppression, while presenting with advanced and probably symptomatic disease at diagnosis was associated with shorter time in both time periods. So we also conducted a frailty model analysis. So while the Cox proportional hazards model, it does account for some heterogeneity in distribution, sort of individuals with the same value of covariates may not have the same distribution. So basically the question was, is an African-American woman in New Orleans the same as an African-American in the same as an African-American woman in, like, Hattiesburg, basically. And so to account for that unobserved heterogeneity, we did perform a random effects or frailty model, with geography and county being our frailty term. And essentially did not find any, like, we still found the same factors as predictors. And again, I think that's a little bit limited by the things that we can ask some of the surveillance data. I just wanted to point out, so these are the counties with illustrating the time to viral suppression by county, with the darkest being, the longest time to viral suppression. So this is 2012 to 2015. And then you see 2016 to 2019. So things got better, but they didn't get better for everybody. And in some cases, they got worse. So I'll point out two things. One, New Orleans got exceptionally lighter. And I think part of that certainly has to do with Medicaid expansion, but New Orleans was also an area that very early on and aggressively piloted rapid start programs. So Crescent Care, their health department clinics in that area. Shreveport was an area that was noted by the health department to have gotten worse. And when they looked at this data, they were like, oh, wow, I wonder why that's happening. And when they investigated, they had lost their HIV providers in that area. And so it was like that for them, that was a directive to say, okay, what can we do? How can we do things like telehealth or do other things in this area in order to improve this outcome? And so likewise, you're still seeing a lot of variability in terms of time to viral suppression, even within the same states. And so, of course, limitations to Southern US only, there might be incomplete, the blessings of surveillance data. And then we also need to ascertain community level data. So we're in the process of doing more geospatial analysis, incorporating census tract data or census data, which includes some community level factors, as well as contextualizing it with qualitative interviews from key stakeholders, as well as community members. And I just wanted to point out, so, the interesting thing about these partnerships is, or the exciting thing about these partnerships, one is when the science is directed by your community partners. And so in this case, one of the epidemiologists from Louisiana said, I'm very curious as to, we have this, experience of redlining, where there was sort of a systemic racism in place where certain neighborhoods could not, it was very hard to get loans, or if they were sort of outrageous, and those communities were sort of very impacted in terms of their real estate value and such. And so she was curious as to whether there was any impact of like this historically racist policy from the 1930s and 40s on HIV outcomes, or some association in like 2023 or in this data set. And so she was the one who wanted us to conduct this analysis. This was actually presented at CROI earlier this year. And so in her data, this was actually a correlation that was made where she used her data. So they were able to access redlining data from New Orleans and Shreveport, and found that if somebody was diagnosed and lived in an area that was redlined at that time, those individuals were less likely to achieve viral suppression and also have a longer time to viral suppression compared to those. So that part, we're like, okay, that's what you want to do, let's do it. And then she got to present at CROI. And I asked them, I was like, so are you guys going to look at this for your public health agency, are you going to look at other health outcomes? Like, this is where diabetes care needs to be more, or this is where other things need to be more. And they're like, yeah, we're going to share this data with our other departments and see if they need to do a similar analysis in this area. And so this grant is ongoing and really informed a grant that we just got notice of award on in the summer, which is we're repurposing our Road to Zero and now calling it Drive to Zero, where we'll be developing a digital cohort of non-sustained viral suppression in the Deep South. So the same three health department states, as we talked about, all CD4 and viral load data gets reported to the state. And so we're partnering with the health departments to identify individuals who can be part of this digital cohort and basically create a limited interaction cohort where we will assess both structural, behavioral, social factors in trying to understand sort of these drivers of non-sustained viral suppression in the Deep South. So this is one of those go, no-go grants. So we have to enroll 1,000 people in the next 2 years, and then hopefully we get to continue the work. And it's really interesting it's one of those things where I'm curious as to what feedback the NIH got when they put this RFA out, because you're talking about people who are not engaging in care, right? And you're saying, enroll them in a cohort, find them and get them to consent to enroll in a cohort. And by the way, you have 2 years to get this done, and otherwise you're not going to be able to continue. Because and when I gave that feedback, they were like, oh yeah, because initially we had said enroll 10,000. And some people were like, I don't think that's going to happen, you guys. And so then they cut it back to a less ambitious 1,000. And when we were sort of preliminary even thinking about this, the health department sort of ran their numbers, like how many unsuppressed people do we have? I think Louisiana had like 8,000, and Mississippi had, probably a couple of thousand, and Alabama similar. So the numbers are there, no problem. The question is getting them to participate. So we're thinking of different ways to do it and incentivize and making cool apps, and of course getting community buy-in as we do it. So we'll keep you posted on how that goes. I'm going to skip this. And so then I wanted to share also, I think this is sort of like the crux of what we're all leading to. So this is actually an EHE R01 that we're working on in Mobile County. So that was on the coast. So this is a type 2 hybrid effectiveness implementation trial. So this is basically an implementation of a combo intervention of evidence-based interventions to basically improve testing, linkage, and viral suppression in coastal Alabama. And so we call it coastal. And this is a partnership with the state health department, but more importantly with Mobile County Health Department. Mobile County operates a federally qualified health center and also a Ryan White Part C clinic. And so they're kind of in this unique position where they can do actually pretty tremendous prevention activities and also do care activities in a way that my clinic cannot do. And so this is the closest that we're going to get to sort of a comprehensive care public clinic in Alabama. And so we were so lucky. We were so lucky that a champion epidemiologist joined Mobile County and reached out to us and said, hey, how can we work? How can we do research with you? I'll go ahead and do the punchline. She resigned last week, but we're going to figure this out. We're going to make it work. This is the joy and the challenge of working with health departments. So why are we working in Mobile County? So Mobile County, as I mentioned, one of the highest prevalence in the state. And in 2019, we put the grant in 2020, had actually recently experienced a huge jump in HIV incidence. And so certainly a particular opportunity of target, again, with the champion. And number 3, an area that the UAB CFAR had never successfully partnered with in the past as well. So our first sort of intervention was the testing intervention. So we want to do a data-driven, community-based, testing operation. So essentially using the data, I talked about the commercial data sets, the surveillance data sets, to kind of identify where are the areas that we want to focus on, where we tell them, hey, with your mobile vans and your community-based activities, let's think about like where are these areas. But at the same time, they have to contextualize it. So we have this whole swath that's nobody in this county's been tested, or nobody in this particular census tract's been tested. You know why? Because it's a cemetery. So nobody needs to get tested in that census tract, right? We don't know that. We don't know that. They can tell us that, right? So that's sort of how that works. So we sort of quadrangulate data from the commercial data sets as well as the state's data sets, sort of saying, okay, where's the testing coverage? Where are the testing sites? Where's the HIV positivity? And then to really hone in, this is where we need to test, where's the syphilis positivity? And so we identify those priority HIV testing areas using geospatial mapping. And then what we do is we asked individuals from the health department and community partners, can you rank each of these zip codes based on your knowledge of the area? What are the testing priorities? And so that was sort of we first created those testing priority zones, with sort of the lightest being like, this is a testing priority, and the darkest being, no, don't worry about that, nobody lives there. And then overlay that with, okay, here's where the HIV screens are. Okay, here's where the syphilis test, HIV positive screens by density, and the syphilis positive screens by density. And so we're still like sort of finalizing. And I don't think I have that map. No, I don't have that map where we also have like dots of, here's where also community testing already occurs, or here's where the testing sites are. And so where do we need to now mobilize, as it were? So that's part one. Part two is kind of adapting the Prepare tool. I don't know if you guys are familiar with this. So this is a tool that's used by FQHCs to essentially characterize the social determinants of health at their clinic level. So it's really administered for clinics to be able to describe, okay, here's our population. There's no scoring, there's nothing like that, but it does ask questions about money and resources, housing stability, food insecurity, incarceration. And so these are all things that are asked when somebody does an intake. So someone who's newly diagnosed comes in and says, hey, you know, we ask all of these things so we can connect in the services. Our purpose was to, at the time of diagnosis, could these 17 items be asked at the time of diagnosis in the field and then get shared at the time of referral? And the purpose is really to just accelerate referral to services as needed, or if they could get connected to services in the field, could that improve linkage? So that's one. And then the last is rapid ART. So, you know, this is something that is not being done. Well, I'll rephrase that. They say they do rapid, and how they define rapid is as soon as they get the confirmatory test, they can start, and they get all the labs, they can start ART. Whereas we define rapid as, okay, you have even an initial positive test in a person with the right epidemiologic characteristics, you start ART. And so we've been working with them to develop their model to implement in their county, or at their health department. And to continue that work. So we just finished all of our trainings. Luckily, 3 weeks before our co-investigator resigned, we have a new co-investigator. So we're really excited about implementing that. And so I think contextualizing that all back to, you know, what we're seeing. So I was on service in August, and this is why we have to do what we're doing. So we are still seeing very advanced cases presenting in the hospital. I saw a 34-year-old. He had been diagnosed about 6 months ago. He actually had PJP, and was discharged on Bactrim, never connected to care, just admitted with multi-organ failure. He actually passed away. I had a 28-year-old. We saw her because she was admitted to psych. She was a known diagnosis, but not in care. She was a victim of sex trafficking. I saw a gentleman who got actually admitted to the MICU for a fentanyl overdose. We were called because he was actually diagnosed with syphilis. And then they also noted that he was positive, but he had been out of care. He was from Mississippi. And I had a very interesting conversation at the bedside with his partner who did not know any of these things. And so we created that as an opportunity for disclosure, testing for the partner, and then and hopefully connection of care for the patient. And then frustratingly, I saw a 20-year-old who had presented. She was in labor, preeclampsia. She definitely has some cognitive delay. She had only had one prenatal visit during her first trimester earlier this year, and she was negative. She was tested at that time. She did show up for a third trimester visit. She felt sick. She had UTI symptoms, and those were treated, but she didn't get a repeat HIV test. And so she presented 1 month later. She's HIV infected, and unfortunately her infant has also tested positive. And this was our first positive in a long time. So certainly a missed opportunity. And so just to highlight, you know, these are not comprehensive, but a lot of ongoing projects sort of organized by Pillar and all like focused on Alabama that are done by investigators at our CFAR collaborators. And of course, there's no way this is happening without extensive collaborations with everyone, both in the community and in the health departments. And this is the key. These are the keys to ending the epidemic. So certainly thank you for your time, and happy to answer any questions or discussion now. Thank you.